So case number one, 55-year-old, 6 feet tall, 190 pounds, BMI 25.8, and with an elevated cholesterol, 10 years, low dose statin, also known as pravastatin, for those of you who don't know what those medicines are. Those are medicines that have been around for a long time, and they're usually started to lower LDL. I'll talk about that in a second. Cholesterol was kind of getting touched. Maybe the dose wasn't as high as it should have been, but diet, not so bad. Exercise, not consistent, but there. So 2 years ago, at the discretion or suggestion of a spouse, there was a CT scan that was done. A CT scan calcium score is for determining, it's a really fast CT. It just takes a picture of just this area with a CT scanner, and it detects how much calcium is in the area. Typically, if you have hit the ages of 60, 70, 80, there's going to be calcium no matter what because of age and damage. But we don't expect that at earlier ages. In addition, sometimes when we have a cholesterol issue that's elevated and difficult to come down, or a family history, atherosclerotic cardiovascular disease, ASCVD, and there is actually an algorithm or a formula to put in your risk factors. Those of you who have high risk, if you're not sure, then you should ask your primary care doctor or your cardiologist. But with calcium score, which was slightly elevated or mild, it showed calcium on one or two of the heart blood vessels. So fine, that means this guy had elevated cholesterol, slightly high BMI so far, and then somewhat responsive to a statin. In addition to now calcium on the heart. So the calcium on the heart was always poo-pooed in the past. Until recently, those CT calcium scores were essentially ignored by a lot of the medical community because there wasn't enough data, but it kept on getting plugged in and analyzed with people who had persistent problems with cholesterol or went on to get bypass or stents. So they found a good association. There's something called a MESA trial that was released, I think in the late 2010s. And it showed that the CT calcium score was a useful metric. I've never really liked cholesterol levels. I think when I was practicing at Advocate, I would do it because there would be no kickback as far as patients not getting the fancier test covered. But with the data in the last 5 to 10 years, elevated cholesterol and trying to hit the target using statins, I think is a little bit lacking. So in a cholesterol test, standard test, you get 4 different tests, sometimes 5 if you can extrapolate, but total cholesterol, LDL, which some people call bad cholesterol, HDL, which some people call good cholesterol, and triglycerides. And that data can be useful, but if you have somebody that has either a family history of heart disease or a heart attack, or maybe calcium scoring, or has a lot of risk factors, that ASCVD risk factor determination formula, then the objective would be to get a fancier cholesterol test. That would be involving fractionation, that's breaking up of the LDLs. So that's one extra test that gives you a better idea about what kind of LDL you have. So the data over the last 20 to 40 years shows that sometimes when you have a heart attack, you'll have an elevated LDL. But just targeting the LDL as the goal of whether we're successful or not, I think is a little limited. Some people have no heart attack and they'll have massively elevated LDLs. So the formula is a little skewed. That's why I like to see a fractionated lipoprotein. Some cardiologists will use it, some won't, but I think it helps to fine tune if the statin is working, if we have to get more aggressive with the person at risk, The fractionated LDL is sometimes considered experimental. It takes the LDL, the bad cholesterol, and it breaks it up into saying, is it tiny or is it fluffy? Fluffy LDL, big pieces of LDL are okay. They typically can't penetrate into the blood vessel wall and cause damage. Small LDL is not so good because those are the ones that can pass through the blood vessel wall, endothelial lining. And then when they stay there and not come back out, that brings on oxidation and damage. So that's the theory of what happens over the course of several years. When you have elevated LDL, but then they're all fluffy, it's okay. And number two, if you're LP little a, that's an extra blood test also in the same fancy tests, LP little a is low, then we probably don't have to worry about damage. So that's when you just say, okay, work on weight, work on exercise, maybe work on lowering that metric that everybody's following, and then we'll see what happens after a while. In this case, the statin medicine that was used 10 years prior, I'm not sure of the dose. The new suggestions with cholesterol are high dose cholesterol or statin. Theoretically, there are some cardiologists who would rather have statins put in everywhere, and I think there's some merit to that, but I really like to embrace exercise, calming practice, and nutrition first. And then if we have to, or if there's really high risk, attack this with a statin or a prescription medicine. Once you have a stent put in, it is a life-saving, symptom-saving procedure, and it's a life-saving procedure in some, but it doesn't turn off our job of trying to still chip away at healthy lifestyle. So even in the midst of a lot of good numbers and cholesterol and a thumbs up from the cardiologist and possibly a decrease in cholesterol or calcium from the CT scan, it still should be chip away at exercise, nutrition, and mindful practice. Blood pressure is controlled with our with CB or case one guy. I would highly suggest, even if we have that stent, as I mentioned, that we introduce some form of resistance. Now, resistance exercise, there's two different types of exercise. One is resistance where you're just trying to grow muscle and make it efficient with exercise and taking in glucose and size. The other is cardiovascular. Both of them have their merits, but I think everybody should have a little bit of both. So cardio is essentially something that'll help you lower blood pressure, help you lower heart rate, and also get you in tune. And typically when you have that cardio type of exercise, cycling, running, long distance hikes, swimming, there's an endorphin and enkephalin response that makes you feel good. And so that theoretically should also decrease cravings. So there's a benefit to cardio, but I think there's also a great benefit to resistance. And this is sometimes a tough sell to my cardio folks. So bodybuilding movements, you don't have to be huge, and that's not the goal. The goal of resistance exercise is to make muscle efficient. So those of us who have some pretty decent responsive muscle, if you have muscle that well adapted, it will actually lower your glucose level. So there's an old trick with a pre-diabetic that doesn't like to exercise or doesn't like to do any medicines. Then we try as best as possible to work on food and macronutrients, but we also ask to walk 10 minutes after each meal because of the fact that a little bit of movement and muscle stimulation drops the glucose. And if you drop the glucose, you drop your triglycerides. If you drop that, you also theoretically raise your HDL and you beat the heart attack. Now, that's entry level, but that's at least the start. In my guys that do on and off stuff, my best suggestion is to have your exercise planned. Most people will do exercise and then fall off the wagon. And that usually is boredom. If life gets too busy and taxes are coming and there's prioritizing that I got to do my work and not my exercise, that usually means that there's no fallback. I mean, everybody's got to crank out something for a goal of muscle girth and cardio endurance, but then not everybody can maintain that all year round. So I take a break, I pulse that, and then I decrease and take a little bit of a break. I don't tell my patients to stop exercise, but I give them a break, and then we pulse again, and then we tailor down. So I think that way, if we think about not exercise for the rest of your life, but exercise in small chunks, it makes it more tangible. The fact that we have it, that some type of exercise is cool, but the fact that we drop off means somebody has to manipulate that or design it so it's easier to maintain for the long run. There should be some form of resistance, some form of cardio. Now, if you can do both together, I think that's fair. It'll kill two birds with one stone. But again, if you don't have experience with designing an exercise routine, then sometimes it just means you go and experiment. I'm hoping that the park districts will open up and the hospitals will open the programs up. You might want to look for sources, family, local coaches, maybe physical therapists to design stuff. The follow-up CT scan for CB showed definitely more calcium deposits to the same artery on the CT scan. So that was a good save. That meant that the average doc or the primary care probably wouldn't have done anything, maybe increase the cholesterol a little bit. But if we just watched, that would have progressed on to a worse than 70 to 80% narrowing of the artery. And those are, especially a left anterior descending artery, that could be a problem. So luckily it was found. Luckily, it was popped open, and the stent will theoretically save life for a short time. I think I mentioned in my videos in the past, stents work pretty well. They open up and stop any kind of pain, but they typically, if the person doesn't change lifestyle, they only last for about 6 years, and then something else pops up. So in CB's case, on catheter, which is the best way to determine what kind of narrowing you have after you have a CT scan, on the catheter, it showed the definite narrowing, and I think it correlated well with the CT scan of like 80% for that LAD, but it also showed two other blood vessels with the beginning of narrowing, I think 20% and 30%. And if we do nothing, that stent will be okay, but the 20 to 30 will grow and they'll choke down. So that's why it's so important not to just leave off now, but start to say, this is a new lease on life. This must reverse now. And that's contradictory to common thinking, because usually if you get a stent, you're in and then you're out. Sometimes overnight, but that's it. And the pain is gone with most people. It's beautiful. Great thing to have. All you have is a little hole in the groin and that gets plugged up. But it also decreases the motivation to say, I need to turn this around 180 degrees, because you went in and the average person, male or female, will go in, get the stent, no more pain, leave. And I'm not sure, I don't think it's covered, but anybody that has a procedure, whether it's a stent, two stents, or an open heart, I would always suggest that's when we pull the trigger and ask insurance to pay for a nutritionist, personalized, and then a physical therapist. But I am not sure if that's covered if you just have a stent. For sure, if you have bypass, all that's included. That's, I mean, bypass is like $100,000 bill. So it should be included to have the dietitian personalize your score or your food. Cardiac rehab also is available, but in a stent, I have to double check. I don't think that's covered. So CB is on its own as far as fixing things. We'll talk about some of the treatment plans. So currently CB is doing okay with the stent, and I think there's follow-up coming. But my suggestion is that we always keep muscle has a potential medicine. So if you think of what medicine does, it takes care of deficiency, or it takes you out of threat. And then the medicine does its synthetic thing to hold the line, help metabolism. But if we only rely on a prescription medicine and don't do anything else to naturally improve metabolism, get the weight down, get the muscle tuned up, we still progress down the bad road. So the thing I would do in this case would be to try to just tease out an exercise routine of some sort. And CB, I'm pretty sure CB has a lot of equipment at home, but that's okay, because I have a lot of equipment at home, but it's boring. The motivation isn't there. It's like, oh, I got all this equipment. I just passed by my treadmill this morning. And it's like, oh shoot, I forgot it's in the corner. But I took it upstairs to inspire me to exercise, but I just put it where I couldn't see it, and now out of sight, out of mind. So I think it's very useful to have a collection of equipment. I would say to negate the boredom that happens when you use equipment at home, you keep it in short bursts. So if you have a countdown to a calendar, if I say, I want my people to join me in Colorado, we're going to hit 14,000 feet by July, everybody has to be working now. And there's a countdown to the deadline. Listen, the objective is to make something sustainable. So for CB's case, either we personally design something that will be cool, CB's job being somewhat high stress, which is kind of subjective. I think everybody has high stress now, no matter what your job is, especially if you're working from home, because there's no boundaries. But I would say we can kill two birds with one stone. Exercise is there, it's necessary, but stress response and controlling that is also necessary. So those of you who know, you can kill two birds with one stone with calming exercise, usually yoga or Tai Chi. Now, granted, those two exercises, yoga and Tai Chi, are not big bulking exercises or activities, but they are useful. Number one, they get you moving. Number two, it also calms the blood pressure. It calms inflammatory reactions inside the bloodstream, and it should help with craving. So you have a couple of different benefits to those two things. The only problem is if most of my guys don't like yoga or feel maybe threatened by yoga, I'm not sure about CB if he tried that before. The second problem with yoga is you have to have somebody teach you. I mean, you can certainly look online and follow some teachers that are giving free lessons. I think Peloton also has a yoga division, but to me, it's not affordable. I mean, it keeps my patients engaged because you have a big screen and you can follow through, and usually the instructors are really well done. We're probably going too deep into solutions. However, I would say the average person should try to kill two birds with one stone. And the other option is Tai Chi. Tai Chi is nice, but that definitely is limited. So Tai Chi will be able to slow the heart rate, slow the blood pressure, and also get movement going in addition to bringing down stress response. Stress response is that part of disease that is very hidden. So if I have somebody that sprinkled cholesterol, maybe tobacco, CB doesn't smoke, but it's tobacco, cholesterol, and then you overlay that with a bully at work or a CEO that's continuing to say, we got deadlines, then that cholesterol and the tobacco is starting to cause the inflammation. There's something to be said of regular happiness. And I'm not saying you have to be jolly all day, but I think that my guys especially, most of us are external. We don't really go inside. It's painful to do that. I think my female patients are well adapted at calming and talking. And maybe that's why they live longer than men. I don't know. I would also check adrenal function in addition to testosterone, because at 55, some things go south. And when the testosterone decreases, trying to build up muscle at that point in time is a little more difficult. So if I just sprinkle on a little testosterone to a guy that's aging, that will get the muscle to respond. And then you pull off the testosterone, you end up with good exercise, a well-adapted muscular system that pulls down glucose and pulls down cholesterol. And you have a fit 56-year-old moving forward. The last bullet point for a CB would be trying to fix sleep and eating. I think when we don't sleep deep enough, that craving starts up, and that's a problem, especially if you work from home. But if you don't work from home and you just kind of muscle your way through one meal a day, 2 meals a day, there's going to be a problem eventually with when you do get to the meal, most of us will ravenously attack the meal and then sometimes not be able to stop. There's something in Okinawa called hara hachibu. It's when you estimate how full you are and you stop and push away from the table when you're 7 to 8/10 full, just as automatic. And I think it's a nice break at the table, but it also gives you awareness that maybe I shouldn't eat that last 15 minutes of food. Usually there's the scientific part is that when the stomach stretches to full capacity, ghrelin and leptin, ghrelin from the stomach, leptin from the fat, send signals to the brain, I'm full, but it takes about 15 minutes. So it could be the difference between 1 plate and 2 plates. And if you don't push back, then technically you have more calories, and that doesn't help with the body mass index. And that'll be my last point for CB, is that body mass index is associated with decreased crap later on. So once you pass a BMI of 23, and there's formulas online that can calculate your BMI, it's height to weight, you can actually trim and have a target. Now, I say that to a lot of guys, and they'll always tell me, I haven't been that low since high school. And that's fine, but it's just a target. Because if the only target my guys have is a cholesterol, you're going to go on to a heart attack. And I think we need more targets. We need more metrics. And that's why if the insurance is good, I would throw as many targets as possible. This is a second lease on life. And if we're not told that, or we don't realize it, then it's like, I'll just continue as is. So I have highly suggested CB change around a lot of things in time, and then see where the metrics lie in about 6 months and then 12 months, and then make sure that we can chip away. Worst case scenario, if we don't have insurance, I've done this old school. Just watch the waistline, watch the muscle size, watch the fitness level, and then see what happens with that. I think a lot of my patients will have cholesterol issues, borderline, and whether we pull the trigger and get the fancy stuff, the blood tests and a CT scan. Oh, by the way, the CT scans are like $50 till the end of the month. And then it goes back up to like $100, I think. So you just have to call your local place and ask your doctor for a script. But until we figure out that we have no more threat, I would say throw as many options as possible. And if something doesn't work, the job of a coach is to redo what we did before so it works next time. It's always okay to fail, but it is not okay to progress on to a full-blown heart attack. So hopefully this gave you guys a couple of ideas. When I post it on YouTube, put down in the comments your questions, and I can asynchronously answer questions. So, and if you know anybody with cholesterol or fighting cancer, send this over and maybe I can give them some advice. So does that make sense? All right, guys. Well, thanks for watching, and try to get outside today. It's nice outside. Even if you go shopping at the mall, just do it and take advantage of the sun and try to eat healthy. I'll be doing next week, I'll be putting 2 more cases, same format. And if you guys have any people that are on the edge, send them to me in the YouTube comments, and I'll consider using their cases next week. Okay? All right, thanks. Have a good day. I'll talk to you again.